Welcome, everybody, to ALPCO's webinar on empowering providers and ACPs and improving IBD diagnoses for better patient outcomes. We have Dr. Kayal with us. We're just going to wait for a few minutes as people roll in. I think, as you've experienced, you need to load the GoToWebinar app on your computer, so it might take folks a couple of minutes. So we're just going to give it a few minutes here and we'll get started. How's your day today, Dr. Kayal?
It's good. The weather is finally kind of nice in New York.
That's why I recommend California.
Yeah, we had like a rough couple of weeks where it was just raining nonstop. So it's nice there's a little bit of sunshine outside. But I actually do think it's gonna rain again all weekend, so we'll take it today.
Say that again?
I do think it's going to rain actually Friday, Saturday, and Sunday, so we'll take what we got today and tomorrow.
Well, hopefully after this you can get outside. So we're here for folks that are just joining. This is Tarika Mansakani from ALPCO. I'm with Dr. Kayal. We're just hanging out for a couple minutes while folks join. We realize that not everybody may have recognized that you have to download the GoToWebinar app, so we could see folks trickling in. So we're just going to give them a couple of minutes to get everything situated and get logged in, and we'll start here in a minute. Meanwhile, we're discussing New York weather.
You know what? The good thing about downloading GoToWebinar now for this presentation is that you'll never need to download it again. So it's
Exactly.
really
Just means we have to have you back in a couple of months.
Now that everybody has the app.
Yeah.
I don't want to click anything on the app because I don't want to break it.
I can see folks joining. So again, for everybody joining, my name is Tarika Mansakani. I'm here with Dr. Kayal, who will be speaking for us today. We're just giving everybody a couple minutes to join before we get our webinar kicked off. So we should get started in a minute or two here. I see the attendee numbers ticking up. Okay, so maybe I'll get us started here with just a quick introduction and some background and some introductions for folks on the line. Welcome everybody to our webinar. My name is Tarika Mansakani. I'm the VP of Global Product Management and Marketing at Novinca DX, comprised of ALPCO and GeneProof. Today at ALPCO, we're really proud to host Dr. Maya Kayal for our webinar, Empowering Providers and ACPs, Improving IBD Diagnosis for Better Patient Outcomes. You may know that ALPCO is focused on stool-based immunoassays for GI diagnostics. And Dr. Kayal is an associate professor at the Division of Gastroenterology at the Icahn School of Medicine in Mount Sinai, and the Susan and Leonard Feinstein Inflammatory Bowel Disease Center. I've had the pleasure of hearing Dr. Kayal speak at a number of congresses and conferences, and Dr. Kayal is an extremely dynamic speaker. Her research in inflammatory conditions has been published in a number of peer-reviewed journals presented nationally, and we are really excited, Dr. Kayal, to have you and learn from your experience. So with that, maybe I can hand over to you and have you kick us off here.
Yeah, well, thank you so much. That was such a lovely introduction. I don't know that I deserve all of that praise, but I'll take it.
Just a quick second. I'm so sorry. I forgot to mention, for the attendees on the line, you do have a questions tab. As Dr. Kayal speaks, I think, Dr. Kayal, you want folks to kind of just, as questions come up organically, right, just kind of put them in there. And we definitely have time at the end of this for Q&A. And also, if you feel like you thought of something after, we will be recording this. you can always send questions in to us and we'll make sure that they get over to Dr. Kayal.
Yes, that's a perfect segue actually, because I think the beauty of this webinar is that it can be a two-way street. So anything that I say or any point that I make today that kind of resonates with you, please do capture it, write it down, put it in the chat box. It is meant to be a very much a dynamic presentation, and at the end, I think where we reap the most benefit in these presentations is where we have some dialogue back and forth, and no question is too small. And even if it's not within the realm of exactly this presentation, we're always also happy to engage with it and discuss it. So certainly as questions come along, jot them down in the chat box, and get ready for some fun Q&A at the end. So the point or the goal of our conversation today really is about empowering providers and ACPs to improve IBD diagnostics, ultimately for better patient outcomes. And this is very, very important because, as we'll discuss in the next 30 minutes or so, IBD really, or inflammatory bowel disease, is really an evolving, increasing issue for our patients, particularly in the United States. And the only way that we can really make an impact on the long-term care of these patients is by diagnosing them earlier and treating them earlier. And so to that end, that's what we kind of want to focus on the talk today. And so we will get started with that. So our aims are three. First, to discuss the growing importance of IBD and why it's important to primary and emergency care settings and providers. Two, to understand IBD and its clinical presentation. This is particularly important to improve that time to diagnosis and time to intervention. And number three, to discuss the interventions for reducing diagnostic delay, which may be honestly the most powerful thing that we can do for patients with IBD. So let's start talking about the growing importance of IBD and why it's important to primary and emergency care providers and settings. So just as a broad introduction, inflammatory bowel diseases, as it currently is defined, is really divided into two conditions, ulcerative colitis and Crohn's disease, each of which are chronic immune-mediated conditions that are characterized by relapsing, that is symptomatic, and remitting asymptomatic episodes. Ulcerative colitis starts in the rectum and it progresses proximally and really is typically limited to just the colon, while Crohn's disease can involve any part of the GI tract and can actually be patchy in distribution and doesn't have to start in one place and finish in the next place. Now, these delineations, Crohn's disease versus ulcerative colitis, are really arbitrary. That is, when Crohn's disease was first identified back in the 70s, it was called Crohn's after the person who identified it. And at the time, the disease was only in the terminal ileum. But unfortunately, these names have kind of carried and been tested in time. And this is how we refer to inflammatory bowel disease as Crohn's disease or ulcerative colitis. I make that point because the truth is inflammation is inflammation, whether it's in the colon or the small bowel. Ultimately, it both kind of falls under that umbrella of inflammatory bowel diseases, and we don't need to put too much thought into, is this strictly Crohn's disease or strictly ulcerative colitis? I think a better concept is there inflammation in the GI system? And if so, where is it? Now, the etiology of IBD is not yet fully understood, but over time, we've increasingly recognized that it's a complex interaction between the mucosal immune system, the microbiome, the environment, in a patient who's genetically predisposed. There's been very, very large genome studies that have identified over 200 different loci that suggest at risk for IBD, and these are shared both in ulcerative colitis and Crohn's disease patients. The issue is that it's not just genetics, of course. As with other, chronic medical conditions that our patients might have, it's not all purely genetically driven. And so there's many studies now that suggest just how important lifestyle factors are in the development of IBD, such as diet and its direct interaction on the microbiome, smoking, antibiotic use, prior surgeries like appendectomy or cholecystectomy. And all of these come together to play a driving role in that they adjust the microbiome and they might change the mucosal immune system. So in somebody who may have some genetics or genetic predisposition, the involvement of all these other factors really plays a driving role in the development of IBD. And we're really seeing that the incidence and the prevalence of IBD is rising significantly and steadily in the Western countries. And in fact, in newly industrialized countries, there's a significant increase in incidence. Now, this is largely thought to be related to the fact that the Western diet, that is KFC, Cheesecake Factory, McDonald's, Wendy's, this is now being kind of dispersed across the world. And countries, newly industrialized countries that are adopting these diets are really altering the microbiome of their residents and their citizens. And as a result, we're seeing a significant increase in IBD. And so that falls or goes more in line with what we just talked about, where the microbiome seems to be at play in patients with IBD. The prevalence of IBD, specifically in the United States, is actually among the highest in the world. And it's estimated that there's about 2.4 million cases of IBD in the United States. Now, in terms of age and sex, we see that the prevalence of IBD is just a bit higher in women compared to men, and seems to peak both in the age range of 20s to 40s, and then again in 60s to 80s. So it has a bimodal distribution. So this is important because just because you have a patient who might be 60, 70, or 80 doesn't mean that they can't suddenly develop IBD. In terms of race and ethnicity, the prevalence of IBD is nearly twice as high among white Americans as it is among Black, Asian, or Hispanic Americans. And so there is a little bit of a race or ethnicity prevalence more in white Americans compared to Black, Asian, and Hispanic Americans. But again, these are not absolute terms. So if you have a patient who doesn't fall into one of these boxes or bar graphs, it doesn't mean that they can't have IBD. Unfortunately, IBD has a significant burden on healthcare utilization, both in direct costs, that means patient and payer costs, but also in indirect costs. That means lost wages that a patient might have because they're spending so much time away from work in the ER or in the hospital or in clinic. And this is one of many studies that have shown a similar story, but in this study specifically, we see that patients with ulcerative colitis had a significantly higher resource utilization and direct and indirect costs compared with patients that don't have ulcerative colitis. And in fact, that excess burden of costs was greatest in patients who have moderate to severe disease. And this is not something that is surprising. We know that IBD is associated with high costs. This was a recent study that looked at administrative claims data and showed that the annual mean healthcare cost for a patient with IBD was 3 times higher than that for a patient without IBD. And actually, the comparison was about $23,000 for a patient with IBD compared to only $7,000 for a patient without. And the costs of care for IBD stem from a couple of different sources. The therapies are quite expensive. The disease requires a lot of surveillance, and so a lot of costs goes towards blood tests, stools tests, colonoscopy, imaging. But also, most of the cost is actually driven by visits to the emergency room, to the hospital, and to urgent care visits. And here we actually see that the healthcare costs for IBD represent over $25 billion annually. And most of it, or a large portion of this cost, is encountered outside of specialist care. That is specifically in the ED and in the hospital for an inpatient admission. For this reason, recognizing how much IBD costs and how significant the costs of IBD relate to the overall healthcare costs in the United States, rapid diagnosis and appropriate therapy early on is key. Because if we can diagnose a patient early on, start the appropriate therapy early on, perhaps we can reduce their recurrent trips to the ER, their recurrent trips to the hospital, and thereby reduce the cost of IBD-associated care in the United States. So let's go on to our second aim, which is to really understand IBD and its clinical presentation. And we'll talk a little bit about the different features of ulcerative colitis and Crohn's disease, their interplay, and how ultimately that plays into what therapies we start and how we monitor these therapies over time. Now, the signs and symptoms of IBD are variable, and in fact, they overlap with many gastrointestinal diseases. Many of these signs and symptoms include diarrhea, frequent bowel movements, rectal bleeding, abdominal pain, decreased appetite, fatigue, malnutrition, weight loss. And what's really key here is to understand that the signs and the symptoms, while they overlap between Crohn's and ulcerative colitis, they do or they can also give you a hint as to whether the underlying process is Crohn's or ulcerative colitis. And we'll talk a little bit about that in the next 2 slides. So for example, in ulcerative colitis, the signs and symptoms really do depend on disease distribution. So in patients who have proctitis, that is inflammation that's limited to the rectum only, the most common symptoms here are rectal bleeding, urgency, and tenesmus. Tenesmus is a very unique feature of ulcerative proctitis. Patients describe it almost as dry heaving of the rectum. That is, they have this constant urge to go to the bathroom or to have a bowel movement, but when they go and attempt to have a bowel movement, nothing comes out. So it really does suggest that there's this dry heaving component, and that's how patients relate it. Now, on the other side, in patients who have left-sided colitis, that is inflammation that is just involves the left side of the colon up to the splenic flexure. Here, the most common symptoms are rectal bleeding, tenesmus, urgency, but you also have presentation or patients presenting with abdominal cramping and diarrhea. So in contrast to proctitis, where there is really not significant diarrhea, left-sided colitis, diarrhea starts to become a significant feature. And finally, in patients who have pancolitis, that is inflammation of the whole colon, here the most common symptoms are essentially what we've already described: diarrhea, rectal bleeding, tenesmus, cramping, but in addition to some systemic symptoms like fever and fatigue. We have a similar delineation in patients with Crohn's disease. Again, the symptoms and the signs might depend on the underlying phenotype. So in patients who have pure inflammation of the small or large bowel, symptoms can be broad and include diarrhea, abdominal pain, weight loss, fevers, and fatigue. But in patients who more specifically have strictures, that is stenosis or narrowing of the small or large intestine, many of these symptoms are obstructive. That is a symptom or symptoms that suggest there's an underlying blockage. These include postprandial pain, so pain when patients eat, bloating, nausea, and vomiting. And then in patients who have fistula or abscesses, that's an abnormal connection or a collection of pus between 2 organs. Here, symptoms depend on the location of the fistula. So it's common for patients with Crohn's disease to have, or it's possible, I shouldn't say it's very common, but it's possible for patients with Crohn's disease to have fistula or connections between their small intestine and their bladder, and in which case they would present with stool in their urine or recurrent urinary tract infections. Or they can have a fistula between the rectum and the vagina, and here the predominant symptom would be dyspareunia or pain with intercourse. And the most common fistula in patients with Crohn's disease is enteroenteric, that is between 2 loops of small bowel. And here the presenting symptom is typically diarrhea and pain. So you can see a lot of the signs and symptoms, while they do overlap, they do also provide a hint as to where the disease is and where the most common area involved is, depending on what the main presentation is. Now, we talked a little bit about how the signs and symptoms of IBD depend on the type. And, you know, it's tough to really compare the 2 disease processes because there's so much overlap, but sometimes there are a couple of hints that can delineate UC versus CD or Crohn's disease. We expect typically more rectal bleeding in ulcerative colitis because we know that the rectum's always involved in ulcerative colitis. But on the flip side, we expect more upper GI symptoms such as nausea, vomiting, pain, diarrhea in patients who have Crohn's disease because we know that the small bowel can be predominantly involved in that condition. There are other ways to differentiate between the types or between UC and CD. For example, because of the transmural nature of Crohn's disease as opposed to predominantly the mucosal nature of ulcerative colitis, certain disease features like fistula and perianal disease are more common in Crohn's disease than they are in ulcerative colitis. I mentioned before that ultimately the delineation isn't too important as most of our therapies are approved for both conditions. But if you have a patient, for example, who is only presenting with perianal disease or with a fistula, and you're not really sure what else is going on, there should be a high index of suspicion for Crohn's disease because that is a unique feature for that disease subtype. Now, what's interesting is that extraintestinal manifestations are common to both ulcerative colitis and Crohn's disease, and they're actually quite common. They occur in up to 40% of patients, and in fact, they can be the first sign of IBD, occurring up to 25 months in advance of an IBD diagnosis. And what is unfortunate is that they have a significant impact on patients' quality of life, and in many situations, they can actually cause more disability than a patient's IBD. There are a couple of different extraintestinal manifestations. The most common are those that involve the musculoskeletal system and skin, and these include conditions such as peripheral and axial arthritis, joint pain, pyoderma gangrenosum or erythema nodosum, lower bone density such as osteopenia and osteoporosis, and eye inflammation such as uveitis and episcleritis. Now, EIMs are kind of fall under a spectrum where some of them get better when you treat the IBD and are actually reflective of underlying IBD activity. And some are completely independent of IBD activity. And whether or not the IBD is adequately treated doesn't have a significant impact on whether the EIM is adequately treated. This is more with uveitis and episcleritis, where the disease or that EIM might be independent, as opposed to something like erythema nodosum, where that EIM is very much dependent on underlying IBD activity. But what's important here, and what I'd like to kind of focus on or have you recognize, is that IBD is really a total body disease. It's not just a disease that impacts the GI system. Yes, the inflammation is largely in the GI system, but patients can present with many, many extraintestinal manifestations. And sometimes, again, it's their first presentation of what will soon to be an IBD diagnosis. And so it requires a high index of suspicion. So if you have a young patient who's coming in and they have erythema nodosum, or they have very significant peripheral or axial arthritis or joint pain, it's important to delve into, are they having other symptoms like GI symptoms? Do they have a family history of Crohn's disease or ulcerative colitis? Could this be a patient who's presenting with an EIM, but really has an underlying diagnosis of IBD? And how can we better get that patient into care? Now, this is very, very important as a whole, because IBD is a progressive disease. And we talked about it at the beginning, how we said it's a chronic disease. And it's chronic in the sense that once the diagnosis is made, it stays with the patient for life. We cannot cure the disease, but it's also chronic in the sense that it is a progressive disease. And without adequate treatment, it will get worse, and it will result in complications like fistula, abscesses, surgeries, strictures, and even in some situations or cases, death. And what happens essentially is that over time, inflammation causes progressive bowel damage, and this results in the complications that I just listed. Now, this slide is very important because it gives us a couple of different windows. We have this early window of maybe prevention where the disease has started. It's subclinical in that patients don't have significant symptoms yet, but maybe they have an EIM or maybe they have a little bit of diarrhea, but it's not significantly impacting their quality of life. They present for care, they get a diagnosis, and then you have this what we call window of opportunity. And during this window of opportunity, early diagnosis and early treatment really has the potential to significantly change the course of disease, such that we go from that top line where we are facing complications like fistula, surgery, and stricture to that bottom line where the disease isn't progressing, but it continues to have relapsing and remitting episodes. Now, our current approach to IBD management involves targeting different inflammatory pathways that have been implicated in disease activity. And I'm going to, before I get into each of these classes, I want to say that there's no perfect way to treat IBD. And it really does come down to a multimodal approach, whereas we select the right biologic or small molecule therapy, but we also talk to patients about lifestyle modifications. That includes adjustments in diet, exercise, stress reduction, because there's no silver bullet. There's no one drug that will cure IBD, and there's no one drug that will induce long-lasting remission. And until we get to that point, it really is about a multimodal approach. Now, to talk a little bit about our current strategies for IBD management, we'll discuss each class in brief. So anti-tumor necrosis factor agents are some of the oldest medications that we have for IBD and other immune-mediated conditions. These include infliximab, adalimumab, golimumab, and certolizumab, so all the MABs. And these target circulating tumor necrosis factor, or TNF. This, of course, is a well-known molecule that causes significant inflammation not only in the GI system, but also in the rest of the body. And again, as I said before, it's one of our oldest mechanisms of action, and we know it works reliably. But it does have some side effect profiles, or some side effects such as the long-term risk of lymphoma and melanoma. And so as a result of kind of those concerns and the potential for increased efficacy, other agents have hit the market. Anti-integrin agents include vedolizumab in the United States and etrolizumab not in the United States, mostly in Europe. These block the action of the integrin, which is on the surface of circulating immune cells and endothelial adhesion cell molecules. The way that anti-integrins work, or vedolizumab specifically, they block the ability of these immune cells to interact with blood vessels and get to the areas of inflammation. So by doing that, it's almost like a stoplight for immune cells. They don't let the immune cells get to the intestine and don't let them cause inflammation. Anti-interleukin 12 and anti-interleukin 12/23 agents include ustekinumab, risankizumab, brazikumab not in the United States, mirikizumab and guselkumab both in the United States. And this is a class that has really seen a significant increase in the last 2 years where all of these agents have hit the market. The way that they work is that they bind the P19 subunit of interleukin 23 on myeloid cells, and they essentially block the activation of downstream inflammatory pathways. Again, they block leukocyte migration, so immune cells can't get to the intestine to cause inflammation, but they also specifically block inflammatory pathways and mediators. JAK inhibitors include tofacitinib and upadacitinib in the United States, filgotinib in Europe. These are pills, and they block the activation of the JAK-STAT pathway, which has been well known to be implicated in the in inflammation in patients with IBD. And then S1P inhibitors are also pills. These include ozanimod and etrasimod, and these block the S1P receptor on lymphocytes and immune cells and effectively trap them in lymph nodes. So similar to the anti-integrins, S1P inhibitors are stoplights. They don't let the immune cells get to the areas where they can wreak havoc and cause inflammation. So it's amazing, right? We have all of these agents, all of these potential drugs. Why aren't our patients all in remission? The fact is we've reached a therapeutic ceiling. Despite having all of these medical therapies available now, we still have really only achieved a remission in a max of about 60% of our patients. And unfortunately, many of our patients require more than one therapy. That is, they get started on their first therapy, they go into remission. After a year or two, they might fail that, or that therapy might no longer be keeping them in remission, and so they have to pivot to the next therapy, and then to the third therapy, and sometimes to surgery. And we see that despite all of these therapies, our surgery rates have improved, but they're still quite high. You can see that the 10-year risk of surgery for patients with ulcerative colitis is about 10%, and the 10-year risk of surgery for patients with Crohn's disease is about 26%. So while it's great that we have all of these therapies on the market now and available for our patients, and many of them are quite safe, we still really haven't broken through that therapeutic ceiling where our patients are all reliably in remission and in a lasting, durable remission. So importantly, what can we do to reduce diagnostic delay? Because I mentioned before, and I showed you that figure where we talked about how IBD is a progressive disease, we understand that to play our part in reducing the burden of disease in a patient with IBD's life, potentially we can diagnose early, treat early, and change that disease trajectory over time. As a first step, it's important to keep a broad differential in any patient who's presenting with symptoms of IBD. This is where history is key, and I know that the ER is busy and urgent care is busy and primary care is busy and there's barely any time to take a breath or a sip of water or use the restroom. But history is really key here, and taking that time to really flesh out a patient's history and their details and their exposures is important, because this could be the difference in terms of what you diagnose them with, right? So taking into account their travel, their exposures, their past medical and surgical history, their medications, even their sexual habits and their dietary habits is key, because it can help flesh out this differential diagnosis. And I'm not saying this just to say this. We have all had situations where a patient is referred for a diagnosis of IBD, but it turns out they have STD proctitis, or they have intestinal tuberculosis. All of these conditions can present in a way that's similar to IBD. And so understanding your patient's history and doing that exhaustive history upfront is important, because it can really change their path and who they end up seeing. Next, of course, is a complete physical exam. And a thorough physical is key here because in addition to establishing a diagnosis, it also helps you establish the burden of their IBD. So in somebody who's presenting with abdominal tenderness and distension, it's important to do an abdominal exam because you might diagnose an obstruction just by examining their abdomen feeling it to be quite distended, hearing tympany. You also want to do an oral exam in somebody who's presenting with aphthous ulcers, because that might be one of their first manifestations of Crohn's disease. In a patient who has recurrent skin tags or abscesses, a perianal exam is key, because as I mentioned before, perianal disease could be a feature of Crohn's disease. And so this might be their first hint of an impending diagnosis. And we talked a lot about extraintestinal manifestations and why a joint and skin exam is particularly important in somebody who's coming in with a chief complaint related to that. Of course, we're going to run studies. Now, I'll preface this by saying we don't have that many studies that are specific for IBD. And so we're not going to be running a giant panel up front. Labs to run initially include a CBC, a CMP, inflammatory markers like CRP, ESR, and a TTG IgA specifically to rule out celiac disease. Again, this goes back to having a broad differential diagnosis. Now, we do not use ESR or CRP inflammatory markers to screen for IBD alone. Why? Because we know that an elevated CRP has a moderate sensitivity of anywhere from 50 to 80% and a specificity of anywhere from 75 to 90%. And so a negative result does not rule out IBD. And in fact, both in my clinical practice and in what has been reported in the literature, about 15% of patients with IBD will have a completely normal C-reactive protein or CRP. And so it really is not particularly helpful. Along those lines, we do not use serologic tests to diagnose IBD. And this is very, very important because for a long time, providers were sending ASCA IgG and IgA to diagnose IBD, but they really have no role in the diagnosis of IBD. They might have a role in the assessment or in the understanding of the prognosis of a patient's IBD, but they should not be used to make a diagnosis. And in fact, one of our most common referrals used to be a patient that had diarrhea and had serologic testing done and it was positive, and they were being sent for a confirmed diagnosis of IBD when those serologic tests are not enough to confirm that diagnosis. So we don't typically use them at all. And I would encourage you to not use them as well because they can just be confusing and not particularly helpful. Stool studies, of course, are very, very important, predominantly because when a patient's first presenting, you want to rule out infection, and that is done with a gastrointestinal PCR and a C. diff test. And of course, fecal calprotectin, of all of the tests and all of the studies that can potentially be done up front, I would argue that fecal calprotectin is the most important because it's an adjunctive test that has high sensitivity and specificity. And essentially, a normal calprotectin excludes IBD in patients who are presenting with nonspecific IBS-like symptoms such as abdominal pain and diarrhea or a change in their bowel habits. What is calprotectin? Calprotectin is a protein in neutrophils that is detected via stool test. And it's essentially released during periods of intestinal inflammation. And there's a lot of data that shows that it correlates quite well with endoscopic and histologic inflammation. And in fact, it correlates better than symptoms do to monitor IBD disease activity. It's been endorsed by multiple gastroenterology associations. Specifically, the American College of Gastroenterology suggests checking a fecal calprotectin in patients who have chronic diarrhea to screen for IBD versus IBS. And so essentially in emergency care and in primary care, it's a great first test to do because it really establishes, or it can be done at a branch point. If you have a patient who is recurrently presenting with diarrhea or abdominal pain, nausea, vomiting, nonspecific symptoms, and you're not really sure what they have, could it be IBS or could it be IBD? Doing a calprotectin is the most cost-effective test because if it's normal, it essentially rules out IBD. Now, if it's high, that warrants a referral to an IBD gastroenterologist or a gastroenterologist who is a specialist in IBD, because then we take over the work. We recognize, of course, that calprotectin is not only elevated in cases of IBD, it can also be elevated if a patient has an acute infection, if they're using NSAIDs, if they have a history of microscopic colitis, if they have a malignancy or significant polyp burden, these can all drive calprotectin. But as a first point of care contact, a calprotectin is a great way to differentiate between is this IBD or IBS. And if it's positive and high, let me get this patient to an IBD specialized gastroenterologist ASAP. These are some of the endorsements or cutoffs that I mentioned have been recommended by the gastroenterology associations. The American Gastroenterology Association specifically recommends a cutoff of greater than 150 to detect underlying moderate to severe endoscopic disease. What's nice about calprotectin is that not only do we use it in diagnosis, but we also use it in prognosis and surveillance. So after we start a patient on therapy, we recheck their calprotectin, and if it's less than 250, we understand that this is associated with increased probability of long-term remission and a reduced probability of colectomy and UC-related hospitalization. There are some nuances with calprotectin. We recognize that it might not be as strong for patients who just have proctitis compared to if they have more extensive disease. We know for Crohn's disease that some patients might not have such a high calprotectin even though they have a significant burden of disease. This relates more to whether the disease is predominantly in the small bowel compared to the large bowel. But regardless of all of these nuances, calprotectin is still a key part of our assessment and our surveillance for patients with IBD. Now, ultimately, the gold standard for diagnosis for IBD is a colonoscopy, but we use that calprotectin value to really pick who we send for colonoscopy. So if a patient has a high calprotectin, then the next step immediately is a colonoscopy. But if a patient doesn't, and they otherwise don't require a colonoscopy, that is, they're not 45 and need a screening colonoscopy, then we probably wouldn't send them for a colonoscopy. There's a couple of different scores that we use to assess Crohn's disease versus ulcerative colitis. Some of the features that are seen during a colonoscopy for Crohn's disease include that patchy distribution, so areas of no activity compared with areas of significant activity with completely normal areas in between. Other features include these deep ulcers, what we call serpiginous ulcers, but on the flip side, very superficial or aphthoid ulcers. We can see areas of narrowing or stenosis or fistula as well. In ulcerative colitis, we also see ulcerations, but these tend to be more superficial or mucosal and not typically as deep as they are in patients with Crohn's disease. Here we see more spontaneous bleeding. That is just during the colonoscopy itself, the mucosa can start to bleed spontaneously. And what's unique about a colonoscopy for ulcerative colitis compared to that for Crohn's disease is that the rectum is always involved in patients with ulcerative colitis. And so the disease starts essentially the minute you start the colonoscopy, you start to see disease in the rectum, which then progresses proximally, that is higher up in the colon. Tissue is mandated, it's necessary to make a diagnosis of IBD, and specifically the feature that we're looking for is chronicity. There's other features such as crypt branching, cryptitis, crypt abscesses, neutrophilic infiltrates. These are all kind of different ways to describe inflammation. But the most important thing is that this disease process on histology tends to be chronic by the time that you make the diagnosis, such that if you don't have that feature of chronicity and you talk to the pathologist and they similarly say, no, there's no chronicity there, it makes you second guess whether this is actually an IBD diagnosis. Historically, we've been taught that granulomas are what's needed to make a diagnosis on histology, but we're increasingly understanding that that's really only seen in about 20 to 40% of patients. And so while it's what's historically or what's been suggested in the textbook, it's not something that we're actually seeing clinically in real life. Cross-sectional imaging techniques are adjunctive ways to make a diagnosis and also to survey patients. These include MRE, magnetic resonance enterography. This is an MRI that's specifically designed to look at the small bowel. Patients drink a lot of contrast here to really kind of open up the small bowel folds, and so you get beautiful images of the small bowel. But we're also increasingly using intestinal ultrasound. This is something that we stole from the Europeans, and we also stole a little bit from the Canadians. Intestinal ultrasound is a great way to assess disease activity, make a diagnosis, and also survey patients in clinic as a point of care assessment. So this is essentially just using a regular ultrasound machine, but instead of looking at something like the heart as an echo would do or the liver as a right upper quadrant ultrasound would do, we're specifically looking at the small bowel and the large bowel, and we're measuring bowel wall thickness and hyperemia. And this is giving us kind of correlative features or correlative measurements that we can then associate with their disease activity. Now I think the point of this entire presentation is really to bring it back to how important early diagnosis, minimizing that diagnostic delay is to patients, because it really impacts their overall patient journey. And you can see in this figure that the patient journey is really marked by ups and downs. the lack of our ability to predict the development of IBD, the lack of our ability to, in many cases, make that diagnosis early on, and then the lack of our ability to predict what the disease course will be for certain patients. Now, with all of these limitations, it's still important, and we recognize that despite our lack of predictive power, we can still bring patients in, make that diagnosis early, start to treat them early, and hope that instead of them having that evolution of disease, they have prolonged remission. And it's not only a provider issue, but the truth is it's also a patient issue to a certain extent. There's a lot of stigma with GI diseases in general. Nobody wants to talk about their poop. I don't know why, I talk about poop all day, but nobody else seems to want to talk about their poop. There's a lot of stigma with a patient who has GI issues or bright red blood per rectum or recurrent nausea, vomiting. And as a result of that, many patients delay seeking care. And some studies from Europe and Asia showed that the time from initial symptom onset to actually seeking clinical help varied from 2 months to 8 years. There's also another survey, or an online survey, that was conducted by the European Federation of Crohn's and Colitis Associations, and it showed that 24% of patients had symptoms suggestive of Crohn's at least 5 years before they went to see a gastroenterologist. This again, has a lot to do with the stigma that's associated with GI diseases. Now, of course, when they finally do come to seek gastroenterology care or start to interface with the emergency department or urgent care or primary care, that's where we start to let them down, and that there is a delay to diagnosis. You can see that there, in some studies, the total diagnostic time was more than twice as long in Crohn's disease compared to ulcerative colitis, largely because of the fact that it can take more time to really clinch that diagnosis once patients are starting to present with symptoms. Again, this goes back to delayed diagnosis is associated with disease progression in both Crohn's and surgery in both Crohn's and ulcerative colitis. So if we can find patients early, if we can get them to come in, or when they do come in, if we can get them to that diagnosis early, intervene during this window of opportunity, we have the biggest impact on their disease course over time. And this is key. Oh, sorry, I missed a slide. There we go. This is where engaging our primary care providers, our emergency care providers is important, because as I just mentioned, not only do patients delay seeking care, but then there's also a delay in diagnosis. So if we can find patients where they are, if we can meet them where they come, and we can start to implement that change early on, we really can have a significant impact on their disease course, but also on those disease-related costs that we talked about earlier. So to that end, in conclusion, we talked about IBD and how it currently affects approximately 3 million Americans, and unfortunately its incidence and prevalence will only continue to rise steadily as we all consume the Western diet. There are a number of unmet needs in IBD, the greatest of which is delayed diagnosis. Delays in diagnosis are associated with disease progression and surgery, and despite all the medical therapies that we have, surgery rates are still quite high. And so as a result, I think as a field, regardless of specialty, if we all come together, recognize these patients as they're presenting, diagnose them earlier, and then pivot them to the right therapy, we hopefully can have an impact on their long-term disease course. And with that, thank you, and I hope we have some questions. And I'll turn it, sorry, let me do this again.
Thank you so much, Dr. Kayal. That was very enlightening. Sorry. Can hear my dog. He's really excited about that presentation too. No, that was very enlightening. Thank you for walking us through that. For those of the folks that might have joined us and missed the introduction, there is a pane on the side of your GoToWebinar. If you go to questions, you can enter in questions there for us, and I'll get them and I'll be able to read them out to Dr. Kayal. Dr. Kayal, from our end, you wrapped up talking about the importance of holistically engaging those primary care providers and other parts of your institution. Maybe can we ask how you do it, or how does Mount Sinai do it? How do you holistically engage those, not just maybe the primary care providers, but even the patients and that stigma that you just talked about? What do you do to help raise that awareness and change how that diagnosis is being made, or the pathway that the patients are finding to get to you earlier on?
So I think that's a great question. And I don't know that we have all of the answers quite yet, but we've certainly made a lot of progress. I think the first thing is to raise awareness about IBD. You know, that stigma can only go away if we normalize it. And so there's a lot of wonderful patient advocacy groups that are working to reduce some of that stigma, to normalize patients reporting symptoms and presenting for care. At Mount Sinai specifically, we have a open relationship with our primary care providers where they can, if they're seeing somebody who is, you know, has symptoms that are suggestive of IBD, we've had joint seminars where we've discussed the importance of actually calprotectin and how that can significantly reduce the time to diagnosis. And so almost all of our primary care doctors, I would say nearly 100% of them, are now using a fecal calprotectin in a patient who's presenting with chronic diarrhea, and using that as a branch point for referring to IBD, gastroenterology or not. They use the calprotectin, and then depending on the result, they send us a message through the electronic healthcare system. Ours is Epic, as I'm sure it is in many other places. And then we, you know, it's essentially a triage system. They send us a message, we put them into our triage system, and then we decide how urgently they need to be seen. And many times we can actually offer them an appointment within the same week. So we do use that calprotectin as a branch point to understand how urgently somebody needs to be seen by IBD or not.
That's fantastic. Actually, that answers what was going to be my second question, which is how often are patients coming to you already with the fecal calprotectin that's been ordered by a primary care provider?
Yeah, I think it depends. Because we've worked, you know, very diligently within the Mount Sinai system to discuss how we use calprotectin, our primary care doctors are really great at assessing it and you know, bringing it up front. I think in other, when I'm getting referrals from other places, truthfully, even from other gastroenterologists, sometimes the calprotectin isn't there. And the reason it just adds to the delay by the time that they're seeing me is that kind of to think about the way that we pitch the IBD patient journey. You know, they present with symptoms, they wait who knows how many months before they see their primary care doctor. Or maybe they start with a regular community or just a regular general gastroenterologist. They describe their symptoms. Then they get maybe some blood tests done. They don't get a calprotectin, but then they get a referral to another gastroenterologist, for example, or an IBD gastroenterologist. So now, and that referral might take another month or a couple of weeks, right? So now you're about 6 months into them having symptoms and a diagnosis hasn't been clinched yet. By the time they come to see me and I order the calprotectin, it takes another week for it to result. And that's assuming that they submit it the day that they see you. So now this is just a cumulative burden of delay, right? Where the diagnosis still hasn't been made and we're just waiting weeks. So it can add to the frustration for a patient. Certainly sometimes I see a patient and I'm like, oh my goodness, there's no calprotectin. I don't really know what you have. And it's important because the truth is, if you have a normal calprotectin, you can argue a colonoscopy is not needed if they're under 45 and they don't meet the requirement for colon cancer screening. And so you can save them a lot of time and energy related to the prep by doing the calprotectin up front and not sending them straight for a colonoscopy.
So that's really interesting. You know, we've heard from a number of KOLs at ALPCO across various forums, and one of the things that we've heard from other providers or other specialists really is they won't always wait for a calprotectin. In some cases, they're going to go based off of urgency of symptoms and go straight to colonoscopy. Whereas what you're saying is very much more in line with the guidelines and maybe where Mount Sinai has evolved, you know, your care practice. How do we get, I guess, the rest of the country to think along the same lines and say, look, like, yeah, maybe it's not a bad thing to reduce those number of colonoscopies, or even if not reduce the number, if this is in guidelines and it's in guidelines for chronic diarrhea, we know the number of chronic diarrhea patients is like 3x that of IBD. Why isn't this automatically being used in screening?
I think for a couple of reasons. The first is that it's, you know, sometimes there's a burden with collecting a stool sample and either dropping it off the same day in, you know, in the doctor's office if they're willing to send it, if they have that set up, you know, complete, or trekking it in Tupperware or in a stool sample kit to the lab that may or may not be close to home, right? So there's a burden of, the collection process. I think the second point is that there is, of course, an increasing incidence of colon cancer, even in younger patients, right? And so when somebody presents with any change in their bowel habits, I think that fear of, is this colon cancer, is still very, very significant, both for patients and providers. And so the knee-jerk reaction might be to do a colonoscopy. Now, I do think that in anybody who's presenting with new bleeding, yes, that person should have a colonoscopy. But if it's just chronic diarrhea, and that really is what the guidelines recommend, then doing a calprotectin first is key. But if there's any blood involved, definitely colonoscopy. You don't want to miss, colon cancer, of course. But if it's just pure chronic diarrhea, I don't think that there's a role for colonoscopy up front. I would start with a calprotectin for sure.
Great, thank you. It sounds like one of the things you're highlighting also is maybe not just the value of the biomarker, but then some of the challenges associated with the biomarker, which is just collection of stool. So, kind of what are your thoughts on solutions or alternatives? I know you mentioned you do not recommend any kind of serological screening upfront. Is this kind of the challenge that we're at till we have future innovation, or are there strategies or alternatives you're looking at Mount Sinai?
No, I think it's just something that, essentially goes with the diagnostics that we have now. It's just a feature of how we make the diagnosis. I joke with my patients sometimes. I say, yeah, it's not easy collecting a stool sample, but the data that I get from that stool sample is so valuable. It's something that I really use not only for diagnosis, but also then for prognosis and for surveillance. So it's not really just one data point. It's actually a data point that, for me, once I start therapy for the IBD, evolves over time. There is, of course, a role for intestinal ultrasound. This is a point of care ultrasound that we do in the clinic in real time, where we look specifically at the bowel wall thickness of the small bowel and the large bowel. And we also apply a Doppler signal to assess for how active the blood supply is to those areas. But this is not to be used in isolation. All of the intestinal ultrasound studies, while they do show that the measures correlate really well with endoscopic disease activity, and even other imaging strategies like MR enterography, I always pair it initially for a new patient who I'm kind of evaluating for IBD. I always pair it with a calprotectin. I think, a lot of my diagnosis and my surveillance really is still very much focused on the use of calprotectin and its evolution over time. I think, maybe novel strategies or novel technology within calprotectin will reduce our time to result, which will be nice. But I don't think that we'll ever get away from stool collection, not only in IBD, in general medicine.
Yeah, it's one of the challenges that we deal with, as a manufacturer in this space. Our goal is, how can we support you in making that diagnosis easier, and that is something that comes up consistently as a pain point. So thank you so much, Dr. Kayal. For the folks on the line, we do have this recorded. We will be sharing out the link, perhaps rehosting the webinar. And if there are any questions as you rewatch, please do send those in to us, and we'll make sure they get over to Dr. Kayal. Dr. Kayal, that was amazing. Thank you so much for your time. It's always a pleasure to hear from you. You're a very dynamic speaker, and this is just incredibly helpful for us.
No, well, thank you so much for having me. And as Tarika said, I'm happy to talk about this more. If anyone has any questions, certainly send them our way. And I hope that everyone found the webinar to be helpful and practice changing, because that's always our goal.
Yeah, I see some requests for the presentation, some thank yous. So thank you so much, Dr. Kayal. We really appreciate it.
Of course.
Thank you, everybody, for joining. And we'll send a follow-up email with the link. Thank you. Goodbye.
Have a good day. Bye, guys.